Welcome to the Moss Report with your host, Dr. Ralph W. Moss.
Hi, this is Ralph Moss, and here's this week's edition of our podcast, The Moss Report. Today, I'm very, very pleased and honored to have as our guest Daniel Rubin, who is a naturopathic doctor based in Scottsdale, Arizona. And I've had the pleasure of visiting with Dr. Rubin at his clinic in Scottsdale in the Phoenix metropolitan area, and admired his work and his influence for many, many years. And so I think it's going to be a great conversation. I'm really looking forward to it. Welcome, Dan.
Well, thank you. Yes, thanks. It's great to be connected again.
Yes, we've been emailing, and we have referred
Yes.
many patients to you over the years, people all over the world, I would say. But a couple of things that I think you can answer better than anybody, or certainly as well as anybody. And that has to do with both your approach to cancer, because you are one of the few naturopaths, I would say, who is almost exclusively dealing with cancer. And but also, I'm interested in your take on the big picture in terms of the political dimension of all of this, and how we move from the current state, how we got to this current state, and how we move from this into a state of even greater integration of naturopathic medicine with conventional or allopathic medicine.
How
I guess we'll begin by talking about what naturopathy is. We're dealing with an audience that uh, is interested but not necessarily expert in these areas, and so what it is and what naturopathy brings to the table in terms of cancer treatment or oncology.
what is naturopathic medicine? It's its own system of medicine. We have our own medical schools. They're approved, they're accredited. Naturopathic doctors graduate from such as naturopathic physicians. It's a postgraduate doctorate program. Then naturopathic doctors can sit for their licensing exams, and there are licensing boards. For instance, in the state of Arizona, we have pretty broad licensure out here. It's a good license. I actually do sit on our licensing board. Um, and really, it's about protection of the public, which is an oath that all naturopathic doctors really take at graduation, is to protect the public. And so naturopathic medicine really does find its roots in precepts. First, do no harm, doctor's teacher, the healing power of nature, treat the cause, treat the whole patient. Those are really sort of where we're rooted philosophically. And I remember when I went to school in 1994, I had to take a class in philosophy, naturopathic philosophy, medical philosophy, which I thought was great because my graduate or my undergraduate is in philosophy, existential philosophy. And,
Mm.
I was taught to argue, right? And so I thought I might want to be an instruction manual writer because I really like detail and taking people step by step. And lo and behold,
Mhm.
I actually kind of became an instruction manual writer.
Mhm.
Uh, I just do it medically and for people with cancer.
Mhm.
And so that naturopathic medicine is the application of the principles of naturopathic medicine to people who come and see us. And there are all different types of naturopathic physicians and practice methodologies, just as there are many types of non-naturopathic or allopathic or chiropractic or osteopathic physicians
Yeah.
around.
And you were really you were the driving force in 2004 to found the Oncology Association of Naturopathic Physicians, or OncANP. And also I believe that you were also one of the maybe four or five uh, people who pushed for and achieved the board certification of naturopaths in cancer. In other words, the FABNOs, the Fellows of the American Board of Naturopathic Oncology. So could you talk about that and talk about the role that those two organizations have played in the sort of the upgrading, if you will, of the naturopathic approach to cancer?
Thank you. No, thank you for the question. Absolutely. That was an idea. It was an idea conjured in the early 2000s, around 2004. And I remember talking on the phone to one of my best friends, Jason Harneman, and we were like, let's do this. And so we got together a interested parties. I think it was Lisa Schuler, Jason, me, Leanna Standish, Jim Billanger, Les Moore, Tim Birdsall. And we sat down and we were in Seattle, Washington, and really started to put this together. We introduced it at the national meeting in 2004 in Seattle to the profession and answered questions. And I think about a month later, we all met in Chicago and made it so. And
Mm,
we developed the Oncology Association of Naturopathic Physicians. I sat as the founding president for the first 5 years.
mm,
And really, the true driving notion was the belief and the fortitude we thought specialization in naturopathic medicine would have. I
mhm.
am a staunch advocate for specialization. We had some pushback, just for full disclosure and honesty and how this developed. There was pushback from many people in our profession about the role of specialization and what that might mean for the profession as a whole, since naturopathy was founded basically on principles and not necessarily specialties, and that if you apply the principles to a person, you should have the right outcome. But we all know, and you more than me on this call, you're like the original with this. In fact, on the introduction to this, I heard your typewriter in the background as part of
Mhm.
the intro, which
Yeah,
means I remember reading your books and your reports, you getting started when there was only a typewriter and no
absolutely.
computers when I was in school. That said, looking forward as oncology was growing and taking some turns, and molecular oncology was coming to the forefront. Small molecules were becoming popularized. There were options other than just conventional standard type chemotherapeutics. And there was sort of this rise of the patient advocating for themselves and saying, like, there's something else there, recognizing that there's a human inside of that body, so to speak. And it wasn't just, how toxic can we make the body to try and kill off the cancer before the human dies, as we know, watching the bone marrow. And there was this realization that there was more. And consumers drove this because consumers started looking for us. And the real reason was, how do you protect the public? All of a sudden we had to have a higher skill in oncology because people were calling on us from a specialty perspective. And that was the driving reason behind developing the Oncology Association, was to show the consumers who really was a specialist and who wasn't, and then they could choose for themselves.
Yes.
And then from that, the American Board of Naturopathic Oncology was developed as an offshoot or an arm of the Oncology Association of Naturopathic Physicians. So the OncANP was the membership arm, and then the fellowship arm or the certification arm was ABNO, American Board of Naturopathic Oncology, and then you could become a FABNO, a fellow to the American Board of Naturopathic Oncology. And that was how it was developed. And in 2006, the first round of board certification took place, and it became recognized by the American Association of Naturopathic Physicians. And that's really what was the birthing of it.
It's an amazing story. I mean, what an
Thank you.
accomplishment to do something like that. You are ambitious, but ambitious and from the point of view of the public, the interest of the public. To even practice naturopathic medicine in the cancer sphere takes a lot of intestinal fortitude, but to form two, this mass, we went broad-based organization, and then within it to single out or have the ability for people to single themselves out as the true specialists is a phenomenal thing. I mean, I've spoken to both groups, and I know many of these people you talk about, but my impression is that the OncAMP, which is the Oncology Association of Naturopathic Physicians is a more broad-based organization in the sense that um, even though it has oncology in the name, um, not all of those people are exclusively dealing or primarily dealing with cancer. They're interested in cancer. Am I right about this? Whereas
Oh my God.
The Fabnos are people you can count on to have become, sort of obsessed with cancer the way that some of us become obsessed with it, and that's their life work, right? I mean, that's the idea.
Yes, for the most part, yes. There are some non-Fabnos who are very good
Yeah,
at oncology, and why they haven't achieved that title, I don't know. But you're absolutely right. There is affiliate status, then there's sort of the fellow status,
yeah,
and I think that's growing. I mean, it's sort of how often the board certification test is offered. You know, new docs are certified. There is criteria you have to meet. It's not just about taking a test, but it's experiential or residency based.
right.
So yeah, you know, I was part of a fantastic, high-powered group of people that I felt incredibly fortunate to be a part of, and took a look at myself and be like, wow, I'm working with these people. I'm, it was fantastic.
Yeah,
So we got it done, and you know, there's been several groups that have come after us and used our bylaws as models and how we did
right.
this with our national organization, which I think is important because you
Absolutely.
really need a collective enthusiasm and consistency. And again, for me, the way that I see things and looking 20 years at the time, which was what, 16 years ago, was trying to
Yeah,
look 20 years into the future about
right.
survivability of our profession and
Uh-huh.
how, you know, there's others that are sort of recognizing, you know, the role of, you know, the functional or the integrative medicine. And I was it was something that I thought had to be done for
Yeah.
naturopathic medicine as a whole, and I'm glad that it happened.
I want to tell you a funny anecdote. I hope she doesn't mind my repeating, but I was visiting shortly after this time with Leanna Standish, who is one of the people you mentioned, and who was the is or was the chief of research at Bastyr University, the sort of the flagship of the naturopathic medical schools. And she and I go back to the early '90s when we were both involved in the founding of the Office of Alternative Medicine at the NIH.
Ugh.
But I was visiting with her, and we were talking this about FAPNO and the certification process for naturopathic oncologists. And she said that even though she actually helped to write the exam for certification, for specialty certification, she herself felt some difficulty in even passing the exam, even though she was the
Oh.
author. And again, I hope I'm not embarrassing her by saying this because it was said in confidence. But it's
I love it.
I'm trying to. I mean, of course, she's brilliant, and she was just being a little jocular, I think. But I think the point stands that when you did this, because of the skepticism in the society and in the medical field, and especially in the oncology field, um, concerning the naturopathic philosophy and naturopathic um, approach, it was necessary to lean over backwards and make this exam, I would say, as tough as possible in order to make sure that at least the first people were of the highest caliber. Am I right in that?
I would say, you know, the thing was is that we hired a company, a third party, a psychometric company, to make sure that this test was unfaltering and that it was, you know, expert, and that there could be no going back and saying like, oh well, this was unfair, these guys just pushed themselves through. And I want to be very clear with the, you know, people who are listening about how that went through. And then the test was fair, it challenged knowledge, and you know, yes, I don't know that we made it as tough as possible, but it was, I think, a very fair test. It tested a knowledge that we thought would be needed to show skill as well as protecting the public and adequate treatment in the field of oncology and naturopathic oncology. And what I say that because when you're engaged in integrative oncology, it's really important that the practitioner understand the conventional treatment, whereas vice versa, it generally doesn't go in that direction. And so
Right.
there's a different type of responsibility that we have, not necessarily a different level, but it's a different type that we have. And so we needed to demonstrate that there was competency in oncology as a whole. I've always, practiced under the belief that if you can speak the language of oncology, that is the first way that you can integrate with a non-naturopathic physician in
Uh-huh.
oncology.
Yes.
And then we speak naturopathic oncology, and as doctor, as teacher, we don't only teach our patients, we don't only teach the patient's friends and family, but we teach others around. And that was really important, especially developing this new term. We invented the naturopathic oncologist in 2004. It
Yes.
didn't exist before. It was now it became a term, and there was this notion of, oh, I'm board certified in naturopathic oncology, but there was a term, naturopathic oncologist. And I absolutely remember when one of my colleagues from, I won't name names and I won't name prestigious institutions, but when I was referred to as a naturopathic oncologist by this one particular individual, and I'm like, okay, it has deeper meaning and it's real
Hmm.
because it's real. I mean, I always knew it was real, and so did my colleagues. But when it became real outside of our little group, that's when I felt like we took another step forward for
Yeah.
the protection of the public.
Yeah. That's a great way of looking at it. I'll bring up something that's a little painful, but I want you to respond to it. I was, I'm always confused whether to say naturopath or naturopath. So I put in Google a dictionary and just asked, they have a little pronunciation guide and they give naturopathy, which is fine with me, like nature, apathy. But up popped alongside that, I, how they have these little boxes that come up to sort of highlight the most important or most popular um, website about a particular topic. You know what I'm referring. I think there's a technical name for it, but anyway, it was something from Wikipedia, and here's what it says. This blows my mind, but I'm going to put this in front of you because you can answer this better than anybody. So, naturopathy, and then it's under that it says political ideology.
Oh,
Political ideology. And here's what it says, painful as it may be to hear this. Naturopathy or naturopathic medicine is a form of alternative medicine that employs an array of pseudo scientific practices branded as, quote, natural, quote, non invasive, or promoting, quote, self healing. The ideology and methods of naturopathy are based on vitalism and folk medicine rather than evidence based medicine. So, this is complete opposite of what we've been talking about. Could you comment on that?
did you? What was your search term that you used?
Naturopathy was the search term.
Okay, got it. So actually, that's not too far from the truth, and here's why. Uh, Several years ago, the World Health Organization did make a distinction between naturopathy and naturopathic medicine, wherein the former lies, I think, somewhat close to what you read in terms of folk medicine and vitalism, whereas naturopathic medicine was the medicine practiced by licensed physicians who have graduated from an accredited College of Naturopathic Medicine. So, does that make sense?
That that does, but it still pops up when I put in naturopathic medicine. It still pops up on the right side with the exact same definition.
Well, then, that I shall comment on. And I would say that I guess you can't just really believe what you find on the internet. You have to fact check stuff. And talking about pseudoscientific ideologies, I would say that that's either really old and maybe
Mhm.
somebody disgruntled wrote that. I honestly have no idea because there is so much science in our world, in our medicine,
Yeah.
so much that, um, and like you said, Leanna Standish, who at the time was chief of research at Bastyr, Dugald Seeley up in Toronto, who is the new and I'm sorry, the current president of the OncANP. You've
Hmm.
been referring to it as OnCamp.
Hmm.
OncANP, or the Oncology Association of Naturopathic Physicians, deeply, deeply rooted in research has received research awards and grants. And I would have to say, people who are listening, it's just another example of being very careful about what you read. If you're trying to educate your local oncologist about naturopathic medicine, naturopathic oncology, or who you may be seeing, it's probably better not to point them to a search engine such as that may be giving false information,
Yeah.
rather to the bios and the achievements.
Yeah.
For instance, people can pull up the research articles that I participated in, so it's far from pseudoscientific.
Right. Well, I know that, but doesn't this hark back, leaving the stupidity of it, and it's not a political ideology, it's a medical
Oh
philosophy,
yeah, yeah,
but doesn't
yeah.
it hark back to an earlier day? I mean, I've, in going around
Yes.
the country and the
Yeah.
world, interviewing many different people with many different philosophies, but you do run into, maybe not so much anymore, but one not so long ago ran into um, self-professed naturopaths or even naturopathic doctors who had this kind of dogmatic
Yes.
attitude, and they were
There's the word.
bitterly angry and opposed to anything conventional in medicine, even when it was obvious that they could put their patients' lives at risk. There's dogmatism, which is often a cover for the lack of evidence. When you believe something firmly, but you don't really have the proof of it, it's easy to just sort of bluster and get angry and get all irate and stuff. And I've run into this. So I'm wondering if this isn't a reflection of 20th century conditions rather than modern conditions.
Uh, I would say, yeah, those were certainly not the physicians that I hung out with or were mentored by.
Yeah.
I could clearly see that. I think, a big driving reason for developing and generating the OncANP and inventing the naturopathic oncologist was exactly that. Their dogmatism is still alive
Hmm.
in medicine today, and it's very clear because I come upon that quite often. It's when a patient comes to me and says, "My oncologist said I shouldn't take this because he doesn't believe in the type of medicine you practice."
Yeah.
And I could have 5 things on a list that are all scientifically validated by a clinical trial. And belief in medicine is a word that I very much try to not use with patients,
Yeah.
because I need some basis. And dogmatism, I agree. Thank you for saying that because it's a word that I think about quite often.
I've read through your website, listenandcare.com, beautiful name, by the way. And
Thank you.
I see nothing, and I'm a little prejudiced, but I see nothing in that website that isn't evidence based. It seems to me that you have a absolutely perfect record in terms of adherence to the principles of scientific medicine. It's just that your scope is much broader than that of the 35,000 members of ASCO, American Society for Clinical Oncology, conventional. So you and your colleagues have, like they say in Germany, they don't talk about anthroposophical medicine versus conventional medicine. They talk about anthroposophically extended medicine. So this is naturopathically extended medicine in the sense that it takes conventional medicine where it is valid, where it is truly evidence based, and then it extends it with other treatments.
I I our scope is different. And the way that we're bred or nurtured, rather, in naturopathic school, I believe is different than what you find in conventional school. I say that because I've never been to conventional school. Um,
Medical.
and I've only been to conventional medical school, sorry.
Mhm.
And I've only been to naturopathic medical school. Th- this is sort of my philosophy is that everybody who graduates to be a physician is a doctor first. Your first form of specialization is when you decide if you're an allopathic, an osteopathic, a naturopathic, a chiropractic, or other forms of physician based, patient centered medicine.
Mhm.
Then you can subspecialize. You can become a nephrologist or a gastroenterologist or an anesthesiologist. And I consider that a subspecialty. And then you can either further specialize from that. And so, because of that, we all have to speak the same language of the body. And so I'm so engaged in laboratory testing, and I use the same labs basically that anybody can. I think it's the way that you look at the body and how you make connections, which is available for any physician to do, regardless of the initials after their name.
Mhm.
And we find great privilege with our office on a hospital campus. We're the first naturopathic doctors ever to be allowed on this campus. We had to petition the management of this campus, we had to get oncologists to vouch for us. And because of our integratedness and how long we had been doing it, and the recognition that we give to conventional medicine, because conventional medicine does wonderful things that I can't and don't do, and we do wonderful things that conventional medicine can't and doesn't do, and
Mhm.
they recognize the respect that we have, and we now we office here. This is, we're in more in mid Scottsdale. When you visited my office, which thank you very much, I still remember that day very strongly. That was in our office in Old Town Scottsdale, which was right across the street from a hospital campus,
Uh-huh.
and we moved up here not too long ago on the hospital campus.
Yeah.
And to add one more thing to that comment is, part of my philosophy, and I'm not shy about saying it, is that this is how I believe. And certainly, I'm not saying that this is how my profession believes. I'm not saying that this is how all of my colleagues nor all naturopathic oncologists. This is just me as Dan, and how I practice. I believe that I, as a naturopathic oncologist, am not as good at killing off tumor cells quickly as, say, a surgeon's knife, a radiation oncologist machine, or a medical oncologist medicine. But I am so very good and so very different at taking care of all the other aspects of the body, recognizing the other health aspects, the physiological principles, maybe the molecular mechanism outside of a tumor mutation, and the complex physiology that it takes inside of one person's body to establish and maintain a tumor and to sort of withhold the immune system and promote all that we know about that oncologic milieu.
Yes.
And that's how I practice.
Also, I think we're getting a greater insight into the life extending um, impact of naturopathic uh, approaches to I'm not saying this very well, but what I mean to say is that improving quality of life actually extends life. And this is
Yeah.
out in a number of recent studies. There was a study that I've written a lot about from MD Anderson, where they looked at who lived and who didn't make it in the early immunotherapy trials, the immune checkpoint inhibitor trials. And one of the big determinants was um, your Karnofsky score, or your ECOG performance
Mm.
status, which means
Hmm.
how able are you to carry out your normal activities? And if you're pretty much able to carry out normal activities, to do office work, do housework, you have a much better chance of living longer. And then there was this recent homeopathic trial in Vienna that you may have heard about, that just came out a couple of months ago, where all what the homeopathic doctors in Austria did was treat the symptoms and side effects of the patients. They didn't try to kill the cancer cells at all, and they practically doubled the survival time of the people who got the actual homeopathy, as opposed to placebo or no additional treatment over chemotherapy. So I think we're seeing these are sort of straws in the wind that are telling us that quality of life is oftentimes denigrated or relegated to a very inferior status. And I think actually to my knowledge, the last drug that was approved by FDA um, to treat quality of life was gemcitabine, for pancreatic cancer, which was what, 1998. So I think in the past 22, to my knowledge, the past 22 years, FDA has not, Food and Drug Administration has not approved any drugs based upon improvement in quality of life. This is a gaping hole in conventional oncology. And who can fill that hole? Uh, there is really no other professional group other than the OncANP or the FABNOs who have the knowledge and ability and the desire and the understanding to play that role. And again, we're not just, I'm not as if it needed justification to improve somebody's quality of life when they're suffering from the ill effects of cancer or from the side effects of the treatment. But in addition to it being a humane thing to do, it also achieves the supposedly primary goal of conventional treatment, which is to extend the median overall survival. And complementary medicine or naturopathic medicine does that. And now we have clear evidence that that is so and that it results in a better outcome. So this of course raises the $64,000 question, which, since this is all hiding in plain sight, it's just right there in the medical record. Why is it, and tell me if this is your impression as well, that the majority of oncologists resist the use of these relatively harmless procedures and treatments that you and your colleagues use, and in particular, where does this idea come from that naturopathic medicine, or whatever you want to call it, holistic medicine, um, contradicts and would decrease the effectiveness? Like, for instance, take the clearest statement that antioxidants would decrease the effectiveness of chemotherapy. That's the nub of the whole question. Where does that come from? What's your take on that?
Whew. You So the antioxidant thing, we obviously can't talk about that because that's like a central core of the argument.
Yeah.
And sometimes, I mean, it's such an argument that eh, I don't even know where to begin on that one.
Well,
But I,
I hope you can talk about it, because I think that gets to it right at the root of whether, or what needs to be done in order for naturopathy to really win its its rightful position within the oncology profession.
that is going to take more clinical trials than have already been put forth because it's a central core, and there appears to me to be a power out there that is trying to continually bring forth fictitious evidence
Mhm.
about the role of antioxidants in annihilating the effects of certain chemotherapeutics. It's honestly not a fight that I'm involved in. Um, what I have done is, through good communication, through exposure of my treatment plans and sent to the oncologist, and just basically being completely transparent, as well as being available for conversation and speaking the language about the principles and practice of oncology. I'm trusted by the people that I work with and that refer to me. And so they let me be and
Yeah.
they let me do my things. One of the things right now that I would say is the most bothersome and ridiculous is when I have to be checked that my protocols, well, I want my oncologist to check it, or they don't accept this, or they don't allow me to take that. And I'm like, I'm a licensed practitioner for the last 25 years. I've never done anything except oncology, little HIV work, but you know what I mean.
Mhm, mhm,
I, I've never, I mean, it's not like I'm checking their dosages on meters squared of gemcitabine or Abraxane or something like that, right?
mhm.
And so that's a problem. But so often that happens when I'm treating somebody outside of the Phoenix Valley, or they're not sophisticated enough. Can I give you a story
Please.
that may help to understand why?
Mhm.
So I had a patient, and I saw them. They were on, I don't remember all the particulars because it was several years ago, but they were, I think, on a gemcitabine based protocol.
Mm-hmm.
And there was evidence demonstrating the use of intravenous vitamin C alongside of gemcitabine at certain intervals. We utilized that protocol. I hadn't seen the patient. They didn't come back for a certain reason. They finally came back. And I found out that the medical oncologist said, you can't take that. It's going to interfere with the chemotherapy and it might kill you, or something
Mm-hmm.
egregious like that. So outrageous. And I was like, it's not true. But how does that make me look in the eyes of a patient? That patient theoretically could have taken that to the board from what that physician said.
Mm-hmm.
Now, note for the listeners out there, that physician was absolutely wrong. Wrong based on data that that physician's profession generated. They're the ones who did the research, not the naturopathic doctors. So I called that doctor.
Mm-hmm.
One, because I wanted to clear it up for the interest of the patient. And two, they don't have the right to say that about me as a licensed practitioner. And three, that doctor needed education. And so we had words. Oh, did we have words?
Mm-hmm.
And at the end of the day, there were two things that came of that. One, that practitioner said, well, please send me that data that you're talking, those data that you're talking about. And I didn't. I said, you could go look for them yourself because I didn't need to take
Mm-hmm.
my time. I had more important things to do. And number two, the reason she said that is because she was told by a colleague in the hallway at lunch that those two shouldn't be used together. That's how she got her info
Yeah.
to then tell my patient that. Therein lies that problem. And I
Yeah.
think that's a story that may give clarity for your answer.
Yeah. I know. And this clinical, the randomized controlled clinical trial for intravenous vitamin C with gemcitabine and radiation, the old protocol for pancreatic
Mhm.
cancer, showed at University of Iowa that there was a near, if I'm remembering correctly, a near doubling of the survival time of the people who took the two agents, vitamin C, ascorbic acid, and the chemotherapy drug, versus those who got the chemotherapy alone. So there is, the old, you used to hear, and you still hear, well, where are your clinical trials? Well, there's a clinical trial, a good one. NIH
Yeah.
was impressed enough with that they, and the National Cancer Institute put about $8 or $9 million into further exploration of intravenous vitamin C at the University of Iowa. Crack team, many people involved at a top Midwestern university, but it's so many times it's like it never happened. And,
Yeah.
it's really quite amazing. I mean, when I wrote Cancer Therapy in 1992, I was criticized by some people who said, well, it's mostly, you're talking about mostly laboratory work, cell line studies and rats and lab animal studies. This was true. I had no choice because at that moment, at least what I was able to extract from the very early internet, pre World Wide Web internet, were mostly laboratory studies. But today, you go in and you see, thanks mostly to China, but also to countries around the world, you see clinical trial data, including randomized control trial data of many of the treatments that you use and that other holistic practitioners use that have been verified uh, through RCTs, randomized controlled trials, the so-called gold standard of treatment, and yet it's just an enormous blind spot among American oncologists, and I would say it also extends to other oncologists in the English-speaking world. That it's even though these things are out there, they're hiding in plain sight, but they don't see it. It's like they're blinded to it. And I'll tell you another personal experience is that one year when my book Questioning Chemotherapy came out, we we took a booth at the ASCO meeting, the big cancer meeting
Oh, wow.
in
Huh.
Chicago. Yeah, and a couple of other less conventional people also had a booth there. Dr. McCoy, who had an immunotherapy treatment, Robert Nagorny, who had as a test for chemosensitivity test for cancer. And the interesting thing was that the oncologists would walk past your booth. It was like you didn't even exist. It was a complete like a Twilight Zone episode. You were like a non-person, a non an invisible presence. And these other sort of non-conventional people had exactly the same experience. Where were they going? Where were they rushing past your booth? They were rushing to the giant displays of the largest pharmaceutical companies who were giving away, Dippin' Dot ice cream, as an inducement. But that's why they went there. They went there because that's the font of truth and money in the cancer field. And if you try to, you're dealing with a kind of epical moment, I would say, in the history of medicine, because if they would pay attention, if they would listen for a moment, they couldn't go on doing what they're doing in the way that they do it. They could go on being oncologists. God knows we need oncologists. I mean, desperately need them, but they couldn't practice the kind of unprotected oncology, if you want to call it that, that they currently do. So I think what you experience there, yes, that is the root of the problem. It gets back down to the attitude of the oncologist, and I would argue, based on my new book, Cancer Incorporated, that there's a monetary core to that, which is the interest of these 9 giant pharmaceutical companies that basically control the cancer field. But that's my take on it. Well, I want to just quickly pivot, Dan. We're talking to Dan Rubin, of naturopathic specialists in Phoenix, Arizona, about his work in really foundational work informing the field of naturopathic oncology. Dan, I want to talk to you about a few of your treatments briefly. One thing that struck me, and I really wasn't fully aware of, was that you aggressively use intravenous therapies. And I didn't know, to be honest, I didn't know that naturopathic doctors could use intravenous therapies. I guess I should have known. Maybe that's a characteristic of Arizona, uh, or a few other states. But you're using vitamin C, of course, but also curcumin and alpha lipoic acid. So maybe we could talk a little bit about the curcumin thing. Curcumin, of course, being an extract of the turmeric root and a little bit present also in ginger root. It's the bright orange color that gives curry powder its coloring. Why do that? And tell me about the legal repercussions of that and the logistical problems of getting a form of curcumin that's suitable for intravenous injection.
Thank you. Yeah, sure, absolutely. A couple things. I do have to say two things. One, my undergrad was at University of Iowa, and number two, I don't know if you and I have ever talked about this, but one of my very first mentors who trained me immunologically was James McCoy,
Oh,
and so
funny, small
yes,
world.
absolutely. And so
Yeah,
to hear his name, that
yes,
you and him were colleagues, is
yes,
I have very fond memories. That was he made the basically the first vaccine that I ever
yes.
used for a patient,
Great
a
guy.
personalized vaccine, of course.
Yeah,
And then yeah, uh, I've always been a real big fan of direct placement of particular medicaments into a person's body via the vein, or by injection. And my early work was with Neo Reardon, and so I was sort of right there with some of the fathers of IV vitamin C therapy. And I remember, Neil is still incredibly smart and talented at science, and the work that he did with his father in terms of, bringing IV vitamin C and establishing it in the journals as
yeah,
even a potential viable treatment. So vitamin C is what I grew up with as a physician, and understanding how it works, why it works, but more importantly, and I think the very most importantly, is how to specifically give it to a person and of one style. Meaning, you can't just be like, yeah, everybody gets 50 grams twice a week or something. It depends on when, what the diluent is, what the other nutrients are, what you administer it with, the speed at which you give it, what your intention for peak plasma levels are. And so vitamin C therapy seems relatively simple to give, but it's not, because you have to be careful. There's a lot of ups and downs in IV vitamin C therapy, and that took years to figure out.
Hmm.
But I still use it every day in practice. Alpha lipoic acid, incredibly important. I was mentored, of course, by the great Dr. Burt Berkson, who I helped co-author the Sentinel articles on alpha lipoic acid. His work that we were able to bring to the forefront, and Keith Block and his group published those articles, and so it was myself, Dr. Burt Berkson, and that Dr. Berkson's son Arthur, who I know they still work together in Las Cruces, New Mexico, and he was the one who put alpha lipoic acid on the map. I helped. I was just a come along, but
Wasn't that
we talk.
with low dose naltrexone?
That's the ALAN or Allen protocol that they developed. Alpha lipoic acid, low dose naltrexone, absolutely. And we wrote those 3 articles several years ago and published those in Integrative Cancer Therapies.
Yes.
But besides, I do have to say, because you did mention about our state licensure, at one time, Arizona, I thought was sort of at the top of the heap in terms of licensure, and it was so broad. In 2002, I remember, I believe it was August 22nd, 2002, is when
Mhm.
our licensure in terms of intravenous started getting scraped away during a sunset review. And through several meetings, our IV privileges were saved, resurrected, if you will, but they were minimized and there were certain exclusions. And so we actually have a less broad IV formulary, if you will, than other states do. And I don't know all the state licensures offhand, but I do know that ours at one time was broader than it is now. Um, the use of nutrients, curcumin and curcumin's a nutrient in the human diet, without question. It's been part of a historical diet. The data on the activity in terms of so like oncocellular metabolic interference by curcumin is, incredibly compelling. I think it's almost unarguable in terms of, across all fields, conventional and non-conventional, integrative, that it's here to stay. And there are some instances where using that directly as a direct in treatment, infusing it, is relevant. I think for me, what actually reigns supreme in my practice isn't curcumin; it's more IV quercetin.
Uh-huh.
And we developed our IV quercetin protocols. Again, it's another age-old, unarguable human nutrient in the body. But as you know, uh, especially early on, oral quercetin is or as a supplement, is very poorly absorbed.
Hmm.
The most absorbable form was in plants, but it was in micro dosages. And look, quercetin protects you.
Hmm.
Quercetin, I think for me, sort of stands cross-armed at the door to your genes and says, "Thou shalt not pass," to
Hmm.
a toxin or something that's genotoxic or
Yeah.
going to injure you. And that is something that we petitioned our compounding pharmacy to make, and we developed a route and a method to make that. And thanks to Civic Center Pharmacy and Tennille and her group, we now have that and a lot of physicians are using this around the country.
Hmm.
Um, it's a viable treatment, and it's incredibly exciting because it's effective. And so I think the combo, especially of IV vitamin C, IV quercetin, and good nutrition, and just sort of like the whole gamut of what we do, and broadly as naturopathic physicians, the use of intravenous agents really just puts it on another level and allows us just another level of treatment for our patients.
It's very, very exciting. Well, I want to ask finally, how you've been impacted by the COVID pandemic. Are you open for business? Has there been any big changes in your practice? Are you doing telemedicine with people who are not able to travel?
Yeah, absolutely. No, thank you. Actually, when we really look back early on, of course, when not much was known, it was impactful. We shut down, and we only allowed certain, minimal staff and doctors. We went to all telehealth, secure platform, of course, and now we're open. We
Mhm.
have people coming in from out of town, which we actually have had even in the summer. Believe it or not, a lot of people travel to Arizona for medicine even during the summer months.
Mhm.
um, we have people coming in. Our doctors are here. Some people choose not to come in for a visit, even if they live in Scottsdale, they'll want to do telehealth, and that's fine. We do have certain restrictions that are self-imposed in terms of how many people we allow in. We've had to create space in our IV room, for
Mhm.
purposes of sort of spreading people out. So we repurposed our clinic. We actually repurposed a business office and made it a secondary IV room so we could maintain the number of people that needed treatment. We're open. We're doing our stuff, and we are absolutely on the telehealth platform and open for people
But of
in
course,
and or out
if
of
they
town.
if they do the telehealth, I'm assuming that they can't get the IV treatments. Is that right?
Uh, well, no, they can. If somebody wants to do a consultation telehealth wise in the comfort of their home,
Mhm.
even if they live in Phoenix, they can still come in and be safely treated here. We have all good precautions and the testing, et
But
cetera.
I
And
mean, people
otherwise,
at a distance. Uh,
yes,
I mean, they can't get. You can't. I'm just assuming that you don't ship these IVs to other doctors to use.
100% we do not
Yeah,
ship those.
that
That
would
is for
be
use in the clinic only.
that would be sort of like uh, 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 making a
Illegal?
market in these substances from FDA's point of view. But
Oh yeah, no, no, no.
you're allowed to use it in your own clinic.
Absolutely, absolutely.
And
And yes,
typically, a
we
cancer
are
patient,
rule followers.
yeah, of course. Typically, a cancer patient would come. Let's say they're coming from another state or coming from abroad. How long would they stay in the Phoenix area? To what's some of the examples of people who wanted to come and use your all your knowledge and your facilities? Um, would how long do people generally stay? Is there a set time, or is there some kind of a program or a protocol that you could say, oh, this is a 5 week protocol or something like that?
Sure. There isn't actually, and I pride myself on there not being because that's the end of one phenomenon. We do not have a protocol, but I tell you how we begin. People do not come to see us unless we've first had a consult with them, and generally to make it the best visit, because some people may come for 3 days because we need to meet with them, go over their lab testing, and we may be prescribing them, say, an injectable substance that they can take home for use, such as mistletoe, for instance, or such as a thymic extract. And they may not require IV therapy, and they just want to come and see us and sit face to face. And that maybe I need to prescribe them some off-label pharmaceuticals. Maybe I need to prescribe them low dose naltrexone or metformin or propranolol or something along that realm. And then they can then take that home and I can continue prescribing for them at a distance because they've come and see me. And that might be a 2, 3, 4 day visit. And maybe there's some people who come and see us and we need to work them up on their dosages of IV therapies. So then we can develop a protocol that they can then use locally because they don't have local naturopathic oncology, but they have an integrative physician or a naturopathic physician who can provide non oncology specialty skilled treatments. But I derive those protocols and they can be carried out locally. I do want to say that my favorite thing is to have people stay at home and be treated locally and not to have to uproot themselves and be here. So all of our sort of programs, if you will, I guess, or when we have people come in here for treatment, I'll say, are designed to be the shortest stay so they can go back home.
Hmm.
And so we talk to the patient, we see where their situation is, what they're thinking about, what their goals are. You talked about quality of life. I mean, that's a big goal. And especially, and this to me is the most important. This is also a notion to listeners out there. If you're traveling for medicine and you're only staying briefly, generally you want to be able to go back home and have that protocol carried out. So if I develop a treatment plan and it's meant for a longer term, I clearly know that this person doesn't live in Scottsdale, Arizona, and they may be traveling back to their state of Utah or Montana or wherever. I try and fashion a protocol with the understanding that it's going to be carried out back home, and that's how we usually develop our treatment plans
And that
because it's
might be
important.
by another naturopath, or if there was a cooperative allopathic
Yep,
doctor.
absolutely,
And if somebody
absolutely.
let's say they want to be treated by you and only by you. I mean, you have a practice with four beautiful women, I must say, and including your wife Debbie Smolinski and the famous Lise Alschuler, another Fabno, and Melissa Coates and Mia Darling, and they all look like, from their bios and everything, like totally capable people. But are you sharing patients, or can people say, no, I heard Dan Rubin on the Moss report, and he's the guy I want to be treating me, or are they shunted over to other people? I mean,
No,
shouldn't say shunted, but are they assigned
yeah,
to other people?
no shunting. No, we pretty much all share them. And Debbie, my beautiful wife, is not seeing as many patients. She has taken over management, and really, she's in charge of the clinic, and
Hmm.
really has made incredible movement in escalating our services and the quality of services. But we sort of all kind of know everybody, and it's like we go out there, we're in the IV room, we're in the treatment room, and
I see.
we meet every morning and talk about all the patients,
I
including
see.
our admin staff and our clinical staff. And so we do it together. And doctors can also, I mean, sorry, patients can also switch and be like, you know what? I saw Rubin first. I
Hmm.
heard about Coach. Can I switch over? And there's no extra fee or anything like that because we're all just one
So
family.
it's sort of the team approach,
Yes.
a little like your neighbors at the Cancer Treatment Centers of America. The team.
Oh, a team approach. Oh, absolutely. Yeah, we're listen and care. Well, if you look at our tagline too, it's personalized medicine, personalized care.
Yeah.
The care was carefully put in there because we recognize that the medicine is what you do when you come in for a treatment or when you meet with your doctor, which is only a small amount of time that you receive care from our clinic,
Right.
which is the communication with our staff, being here, dropping by, even just being in the waiting room, calling in, emailing. And that's just as important as the medicine is
Right.
the care. That's why we listen and care.
Thank you. Well, it's been a
You're welcome.
tremendous, a
Thank you.
tremendous pleasure to listen to you. As I said earlier, I feel we could go on for hours. It's endlessly fascinating to me what you're doing, and I am so impressed, Dan, with how you've developed this program, how you've developed, and it's uh, it's really exciting. I hope we can revisit again in a while and get into some greater depth about all kinds of questions relating to your treatment philosophy and your experiences over the years. I wish you the best, and I'm sure that things are going to just develop even greater in the future. So thanks again, and for the Moss Report, this is Ralph Moss.
Thank you for listening to The Moss Report. Visit our website at themossreport.com and subscribe to hear more discussion of cancer treatment options, alternative research, and more. For more information about Dr. Moss and his work, including scheduling phone consultations, go to mossreports.com.